presenter is Dr. Shobita Shoravi Ratha.
Good morning, everybody. At the outset, thanks, Team AI, for giving me this opportunity. So let me discuss the clinical profile and outcomes of pediatric ocular myasthenia gravis presenting to our institute. With this 7.5-year-old male child who came to us where his parents complained that he has drooping of eyelids since 1 month. They also told that there was a diurnal variation. On examination, visual acuity was 6.6N6, but as we see, there was acquired ptosis which has developed 1 month ago. There is presence of lid crease with PFH being 7 millimeters and MRD1 2 millimeters in both the eyes. On further fatigue test, it was positive and eyes test was also positive. On ocular motility examination, we see elevation limitation in both the eyes, left more than the right. However, rest of the ocular movements were normal. Serum ACH receptor antibody and MRI was requested, and in the OT next day, a neostigmine test was done, which was normal. HRCT thorax was also asked, which ruled out any thymoma or thymic hyperplasia. With this clinical findings and ancillary tests and laboratory diagnosis of juvenile myasthenia gravis was made, the patient was started on oral pyridostigmine 30 mg thrice daily for a period of 6 months. We have been following up this patient now for a period of 1 year and has been stable with no recurrence or no onset of systemic symptoms. There has been improvement in motility and deviation. So 1 to 5 cases per million of JMG in children less than 18 years present per year, which is approximately 10 to 15% of all cases of myasthenia gravis, and 15% of all patients of myasthenia have isolated ocular involvement as the only manifestation. However, is there a literature in India stating how is pediatric myasthenia gravis presenting? Oh my God, it's not there. And this brings us to our study where we wanted to study the presenting signs, therapeutic interventions, and clinical outcomes of OMG in a pediatric age group. The study period was from April 2021 to 23 of February. A retrospective case analysis was done, and all those children who had a follow-up period of 6 months were taken into consideration, who presented with ptosis, extraocular motility limitation, diplopia, with clinical evaluation corroborated with the ancillary test. We excluded those who had congenital myasthenia, any systemic associations, and neurological lesions on imaging. This was a diagnostic criteria which was initially given by Cooper-Smith et al., followed up by Stacy Pinellas et al. In her paper, and we did follow this, where the criteria is ptosis and extraocular motility. One of them should be present, where a fatigue test can be positive with no pupillary abnormality except from a prior ocular disease like surgery or physiologic anisocoria. One of the ancillary tests need to be positive: fatigability, recovery after test, edrophonium bar neostigmine test, which we commonly do nowadays, abnormal RNS or abnormal acetylcholine receptor binding antibody level, age at presentation between 1 to 18 years with the absence of generalized symptoms. And we classified these patients based on their improvement, whether they recovered, where there was improvement in ptosis and motility, partly recovered, either of them improved, refractory, no improvement after 3 months, recurrent within 3 months after stopping treatment if they recurred. So treatment was started in all our children because either ptosis or ophthalmoplegia or strabismus in children are potentially amblyogenic. So we started them on oral pyridostigmine 2 to 4 mg per kg body with no clinical improvement or worsening. They were added on oral steroids. If refractory, a detailed re-evaluation was done. After an oculoplasty, opinion was also sought, and recurrent cases, immunomodulators was added in consultation with a neurologist. Our results are there were similar number of male and females. The age of onset was slightly older, 8.1 plus minus 4.9 years, with an average follow-up of 6 months. Most common presenting symptom was ptosis, with clinical tests being positive in majority of them in more than 50%, and most of them responded to pyridostigmine. On ocular motility, it was limitation of elevation which was more common than the other motility problems. Coming on to investigations and the test, the Cogan lid sign, the Simpson size test was positive in 67%, and ACH receptor antibody was only positive in 28.6%. None of them had brain or thymoma, and RNS was not done in any of our patients. The treatment given was pyridostigmine alone, to which majority of them resolved and responded, and then a steroid was added if they didn't respond, and only 3 of them needed immunomodulators. Thus, juvenile ocular myasthenia is a clinically distinct entity in relation to adults. It's not the mini pediatric, it's not the miniature of the adult variant. Early suspicion and prompt management is necessary in all to know a complete recovery. Oral pyridostigmine can be restarted as primary modality with add-on steroids. Though rare chances of generalization, a regular follow-up and careful history taking is essential essential. So what's there in literature? Peripubertal age group of ocular myasthenia generally presents 5 years of age. In West, it is usually less than 5 years, with more preponderance in females. What we found was a marginal older, not pubertal, but between prepubertal and pubertal age group. Majority of them had equal predilection. Chances to generalization is less as compared to adults, which we did find in our time also. Response to oral steroids and pyridostigmine is there in literature where they start both together, whereas we found more response with pyridostigmine only. Ptosis and stabilization, we had comparable result. Thank you.
Thank you, Dr. Sovita. I had one question. If the patient is having only ptosis, we should start on pyridostigmine only. But if the patient is having ptosis along with external ophthalmoplegia and this strabismus, so it's better to start pyridostigmine along with the steroids.
That's the conventional teaching, and we did that. We were doing that, but we deferred here. So in children, we did only with pyridostigmine, and majority of them resolved. If by 1 or 6 weeks follow-up, still we added on pyridostigmine elevated dose, they didn't improve, then we added on steroids.
Okay.
That's how we differ. The only difference between us, except for the age and demography little.
Okay.
If any of your patients been started on pyridostigmine empirically without just clinical suspicions with all other
Like
tests
a therapeutic trial, sir?
Yeah.
No.
It's all proven
Yeah,
test.
most of them had symptoms. We didn't do that.
Okay. Thank you, Dr. Sovita. So this is the end of the season. All of the participants almost stick to the time. So a big thank you to all of you so that we could end the session in time.
Good. One small advice to the youngsters who are presenting. Do not include too much information in a slide. You can photocopy the entire Kansky book and put it there. It doesn't help in understanding, putting across your view to others. So stick to 3 or 4 salient features per slide. And if it is 5 minutes talk, you present about 10 slides or not more than 10 slides. I've seen many people 5 minutes, 25 slides, 35 slides will be there and lot of slides will be left unpresented. That doesn't convey a good impression while assessing the free paper. Since it's a free paper, you must stick to certain rules. 1 is time. 2, less number of slides. 3, less number of points for each slide is all advice I give you. But you all have done a good job. Thank you very much.